So what happened with me and John, I've known John for probably close to 40 years, 35, 40 years. We met on the speaking circuit, basically running around the world in various countries and various cities and advisory boards. And he plays tennis. We just liked each other, just became friendly. And I got on this list of a letter he would send out every year at the end of the year. I'm sure some of you either do this or know people who do this, where you get a letter about how their family's doing with pictures. And through that, I got to know his kids and his wife. Never met his kids. I think I met your wife once or twice, but I got to watch them grow up. About 8 years ago, it got converted to email attachment. And he was always remarkably honest, similar to Bill here, just forthright. I mean, you get this letter, and it wasn't like everything's going great. I got one kid that's got some problems, and I read a lot about that. We watched him progress and go to various programs to get better, and it was really pretty honest. And then a year or two ago, I think you wrote a book about Matthew, his son, and which I read, and it's just very honest. He's a great writer, and he's a really great speaker. And then it was December, this past December, I got an email at work with an attachment, and here's the annual letter, and I thought, okay, don't open this now. This is not a, whack-a-mole email thing to do. You need 20 minutes for this. So I go home, pour myself a martini, and about to eat some dinner, and I read this. And it says, dear friends, or however it starts it, this is the last time I'm going to write an annual letter. And then he describes his illness and the pathway for a few years. And he's going to talk about that. And I thought it was very stunning. It was shocking. And then we got to talking about it. And I said, hey, do you want to talk about it? Like, what's it like to go through what you've been going through? And how do you feel about the future? And I mean, I'm sure we'll have some interesting things to talk about, and so I'm going to invite John. I think it's brave to do this. I have no idea where this is going to go. It's a bit of a risk, but I trust you all, and I trust John. So let's see.
Well, to be honest with you, I don't know where this is going to go either.
They have your slides.
The slides I have there, but this is the talk. So, as Paul said, he likes to have philosophical discussions at this meeting. And when Paul asked me to put together a talk about my own terminal illness, you can imagine that I had a great deal of trepidation. Other people have suggested that I write about my illness, but I kept asking myself, what's the point? But Paul and I have been friends for 40 years, so it was difficult to say no to him. The assumption is that doctors who have more experience with death and people dying would have significant wisdom when it came to their own terminal illness. But when I discussed this with another well-known cardiologist who has cancer, we both quickly said, we don't know anything about cancer. And having never done it before, we really don't know anything about dying. We all have to die sometime, so it's not the concept of dying which is so terrible, but the fear of being in pain and suffering scares the hell out of me. Because you are physicians, Paul assumed you might be interested in the details of this story. I have been a very healthy and physically active person all my life. I play singles competitive tennis, and I've gone backpacking every year, as shown here, on the John Muir Trail twice. This trail consists of 223 miles between Yosemite and Mount Whitney in the Sierra Nevada. I carried a 50-pound backpack, an average of 8 miles a day. The last time I did this, I was 73 years old. A routine blood test in January 2023 revealed a slightly elevated creatinine of 1.6. My internist said, let's get an abdominal ultrasound just in case. In April 2023, I had a left nephrectomy for renal cell carcinoma, chromophobe cell type. The tumor was contained to the kidney and all 20 lymph nodes were negative. And so like Donald Trump, I thought I had dodged a bullet. An abdominal MRI in August 2023 showed no evidence of disease. When I started to get abdominal pain in September, I assumed it was gastrointestinal discomfort with cramping pain. The 6 doctors who took care of me also thought that this was a GI problem. They were all wrong. I had a CT of the abdomen in Thanksgiving week of 2023. I had a 9-centimeter mass in the left nephrectomy bed, which was now surrounding the aorta, some of the bowel, and the tail of the pancreas. Everyone agreed we did not need a biopsy. Within a few days, I was placed on immunotherapy with ipilimumab and nivolumab infusions. And as Paul has said, every year I send an end-of-the-year letter out to about 500 friends, family, and colleagues around the world. Some of them actually read it, I guess, like Paul, and tell me it's a nice way to keep in contact. In December 2023, after 40 years of writing this, I wrote that I thought this would be the last letter. I assumed that I would be dead in a few months and started making plans to have a physician-assisted suicide. After speaking with the physician in charge of hospice, I had to speak with the pharmacist, and I was told that they would have to hand the medicine directly to me, so I would have to be healthy enough to receive it and administer it myself. I found out from the pharmacist the oral concoction for assisted suicide consists of benzodiazepines and barbiturates, but the killer is 100 milligrams of digoxin. What irony for a cardiologist to end his life by taking a plant alkaloid that I have administered over the decades to hundreds, if not thousands, of patients. As a cardiology fellow, I tested short-acting digitalis and wabane preparations for lowering the repetitive extrasystole threshold. I know how digoxin kills. When Paul asked me to give a talk on this topic at his interventional conference, I reluctantly agreed because I thought there was no way in hell that I was actually going to have to do it. I would be dead before I had to embarrass myself before a group of physicians, whether friends or strangers. But a year later, here I am. So what have I learned this past year? I've learned that no matter how much love you have surrounding you and support from friends and family, this is a dance we ultimately do alone. It is an isolating experience. We all have had the awareness of telling ourselves that each of us could die any day. But it is existentially different when you know that there is a mass of sarcomatoid tissue growing inside of you that wants to take over your body and end your life in the process. Every day, I wake up with the knowledge that I have cancer. If I have any abdominal discomfort, even if it turns out to be a gas bubble, I'm convinced that today is the start of the downward spiral that ends in my demise. I don't mean to be depressing, but it's hard to get around the fact that it is. Those of you who know me know that I am a joyful person, but especially as a physician, there are lots of times when I participate in dark humor about my dying. During a recent USTA tennis match, I was playing someone at least 25 years younger than I was. After he won a hard-fought first set. As we were changing sides, he saw how fresh I looked and asked me how old I was. I smiled and said that I was 76 years old. He was amazed. He was exhausted and had already gone through 2 wet T-shirts. But I said it's not the age that matters. It's the fact that I have kidney cancer that's the problem. The next set, I beat him 6-1 and won the tiebreaker. That felt really good. So what else have I learned? I've learned that I don't have a bucket list. I have accomplished a great deal in my life, and I have been extremely happy with an amazing balance of hard work, incredible family, and wonderful, pleasurable experiences. I've traveled all over the world, working with colleagues and sharing any knowledge I had with other physicians. In the 1980s, I helped develop digital angiography and performed the first digital coronary angiograms in the world before most people understood what it even meant to digitize an image. In the 1990s, I helped to develop intravascular ultrasound imaging and perform the first human intravascular ultrasound coronary images at a time when no one knew what this technology was capable of doing. Like Galileo with his new telescope, we had a new instrument that could show us the equivalent of how equivalent to a low-power histology in a living person. It's very rewarding during this conference to watch all the cases that they've been doing using intravascular ultrasound-guided angioplasty. Because I realized that the FDA was impeding progress in interventional cardiology by being too restrictive with new technology, I went to Europe and worked with Antonio Colombo in Milan to use intravascular ultrasound to try and decrease coronary restenosis. Through that process, we discovered that coronary stents could be optimized with larger balloons at a higher pressure. Antonio and I received the Mason-Sones Lifetime Achievement Award at SCAI this past May for that work. After working in Milan, I came down to Scripps and worked with Paul Tierstein and Richard Schatz, showing them what we had learned about stenting with intravascular ultrasound guidance. I have exhausted my wanderlust, and I'm doing exactly what I want to do. I continue to work half-time seeing patients, doing PFO closures and research. I play some tennis and spend time with friends and family, knowing that it won't last for long. I've become a gentleman farmer and planted many fruit trees, avocados, and I have two beehives to help pollinate them. My little girls make tons of honey, which I have learned to extract and share with my friends. I formally retired from UCLA at age 68, but have been called back each year. Rather than stopping interventional cardiology abruptly, I was able to transition over a few years as I cut back from taking call for acute STEMIs, eventually giving up coronary angioplasty and TAVR procedures. But I continue to work half-time, seeing patients and staying active with PFO research and procedures. Medicine is not only a profession, it becomes a defining part of who you are. It is difficult to give that up completely or suddenly. I have received recognition from the clinical societies as well as by my own patients. Oh, sorry. I guess did I go through this? Sorry, wrong slide. I believe, this letter attests to an endowed chair in my name in interventional cardiology at UCLA from grateful patient and philanthropist. So I still feel that I have something to contribute. I believe that we have recently discovered a connection between PFO, coronary artery spasm, with ANOCA and migraine, as I described this morning. If this connection proves to be valid, part of my legacy may be that it will be called the Tobis triad. I'm counting on you to carry that forward. You might begin to wonder if doctors should share this information about their diagnosis of a terminal illness with their patients. I tried it twice and found that it was a terrible idea. The patients began to cry in the office, and I realized that I was burdening them with this information instead of helping them to relieve the anxiety of their own illness. These are some of the books that I've written in interventional cardiology. As a scientist, I am by nature skeptical and question the validity of what people tell me. This was even true when I was 12 years old and was kicked out of religious school because I questioned a teacher why I should be memorizing this stuff from the Old Testament when no one could prove to me that there was a God. I do not believe in an afterlife, but as the Bible says, dust to dust, and we will all be consumed by an expanding sun in another few billion years. I don't even think of the possibility of an afterlife as something that would be particularly pleasing. The irrationality of that type of magical thinking just irritates me. We all must die, and when my time comes, my major concern is that I don't want to suffer. I'm only saddened because I have had, and I'm having, such a good time being alive that I want the fun to continue. After living with cancer for 1 year, I do know something more about dying than I did before. Living with cancer is death by 1,000 cuts. Either from the tumor or the medications, you keep losing functionality. A thyroid here, adrenal insufficiency there, folliculitis on top, abdominal distress all the way down. The time-consuming infusions, CTs, MRIs, and PET scans, weakness, fatigue, cold intolerance. Every needle stick hurts. I'm alive today because of the amazing advances in understanding the molecular biology of cancer. The checkpoint inhibitors and the anti-VEGF medications are working so far. I recently had a procedure called electroporation, where an electric current is passed into the tumor through a needle through my back. The electricity doesn't ablate the cancer, but it opens the cell pores and tumor antigens escape. This stimulates your lymphocytes to recognize the cancer cells as foreign, and the T cells then attack the cancer. There are newer treatments like mRNA vaccines that take the cancer protein sequence, make an mRNA that is then injected back into your body as a vaccine. Who knows? I may still be alive with cancer next year at this conference, or I may not. On the other hand, one benefit of dying is that I will no longer have to take the ridiculously wasteful university compulsory learning sessions on such things as sexual harassment and violence in the workplace. It has been, although some may consider that an extreme form of trade-off. It has been a wonderful experience to have spent my life as an interventional cardiologist. You should all be proud of what you do every day. Thank you.
We can ask questions, talk some more. I'll just start by saying, I think you mentioned some of it, but having gone through this experience as a patient, fortunately, I haven't had that much of this in my adult life. I had a couple of CT angios and didn't even like holding my arms above my head and having the dye circulating. I'm just like, this just doesn't feel that great. Does it make you a better doctor to have gone through this and to know the death by 1,000 cuts and just like all the annoying things that happens as a patient and waiting and the cold room and all that stuff?
I don't think so, but I think that's just part of my personality. I think I've always been very sensitive to the patients and what they're feeling. So I can't say that it's really changed me and how I approach patients differently than it did before. It might for some people, but it didn't for me.
You were always a compassionate, nice doc.
I believe I was. So I can't say that that has made a difference. It makes you angry. You say, fuck, why me? And I think it's poison. I think I've been poisoned by corporate America. There are chemicals now in all of us, these forever chemicals that are carcinogenic. And younger people are getting colon cancer and what was the other cancer that it is, whether it's lung or kidney. And it's in the environment. It's in the water we drink. It's in the plastics. It's in these forever chemicals. And so that's why I think I got this.
Anybody have any other thoughts?
I'm just,
Let's do a podcast.
Yeah, I gotta get your contact info. I want to do it. I mean, one of the questions that I would like to ask is, if you could go back to yourself 30 years ago, what advice would you give yourself?
What advice would I give myself? More sex? I don't know.
Okay, you heard it here. You guys. Yeah, more joy is sort of what you're,
Yeah, but the
you already
thing
had
is,
a lot of it.
I have had an amazing life. I've had a lot of joy, a lot of love. I've had a hard life. Paul sort of talked about it a little bit. Our second son had a lot of troubles and wound up in a therapeutic boarding school. So it's not like it's just been, fun and roses. But I've had a great life. I've done what I wanted to do. So I have no regrets.
That's awesome. Do you think with knowing what you're knowing now is helping you be more present in the moment and enjoying the memories each day?
No. There's this thing about, wellness of doctors and being present in the moment, and man, I'm there. I don't know how you could be more present in the moment, and I'm doing what I want to do. The problem is the medication makes me weak and sick and lack of stamina. So that makes it hard for me to continue to enjoy life. But it's the medication. It's sort of like this trade-off. Well, if I don't take the medication, the tumor's going to overwhelm me and kill me. So I take the medication, and then, you don't feel so great. It's not as bad as chemotherapy. I'm not throwing up. But
You've got great hair.
yeah, I've got great.
I'm jealous.
So people come up to me and they say, wow, what a great tan you have. You really look so healthy and everything. And I say, I've got adrenal insufficiency. This is the effect of ACTH from that fucking medicine. So, you fool around with yourself, but that's what's going on.
And your colleagues, you see you go to work still. I'm still going, and
Yeah.
is it weird? Does everyone want to say, like, I'm so sorry, or is there a way to get past it? Because I'm sure you don't want to revel in that, I'm guessing.
Yeah, I had no desire to hide this. So I sent out that information so that people would know. But it is a little weird when people come up to you and say, "How are you doing?" Say, "Oh, I'm dying." What can you say? People care about me, and they've been very supportive. But there's really not much anybody else can do besides the docs who are taking care of you.
One of the things you said there, which struck me, was that we all die alone. And that is something to ponder, because he certainly has, you have quite a supportive family around you, but still it's something that you do alone. I was really struck by that.
It was interesting because that's something that often comes up about when you're dealing with the death of a patient in the lab, that you often are very alone. So that was the part that resonated when you said that, is there's a crossover, obviously, with what you're doing, but how we deal with that emotion, because it sucks to be alone, right?
Yeah, fortunately, I haven't had that many patients who died, but it happens. It happens to all of us. We're in a pretty high-risk subspecialty. And that feeling just is terrible. It's almost, I think that's worse than what I feel about myself.
there's a saying that, there are no atheists in the foxholes. And,
I'm in that foxhole right
well,
now.
but you're an atheist. You remain one.
Yeah.
So I find that interesting. There's no pull when you get this to kind of pray, and none of that. You have none of that.
Pray to who? Pray to what?
Yeah, that's. I was like, I did that at Bill's course. I give a talk on how to talk to families about bad outcomes, and one of the things I say is if the family starts bringing up God, just go with it. It's very comforting to a lot of families when you have a bad.
Yeah, I never, patients say that to me as well. They're on the cath table, we're about to do a procedure, and they would say, I'm not anxious, God is working through your hands. And I don't start arguing with them. I say, yes, ma'am, right here.
Hey, John.
But I don't derive any feeling of appreciation or release or relief by thinking about an afterlife or a supernatural being. So it doesn't help me to think about that or think that that would be great. So I don't have that. And I can understand, for those of you who are religious, that it helps you. It helps you get through that anxiety. I don't have that. But frankly, I don't think I miss it.
John, I was listening very carefully when you started to discuss the potential for doctor-assisted suicide. And I'll set my question up in that my wife is Armenian, and the Armenian community in Michigan is a very small, tight-knit community. And there was an Armenian physician named Jack Kevorkian that I got to know extremely well, both professionally, as he was a pathologist where I trained, and personally, because I saw him at just about every Armenian affair in Detroit. And I found him to have done a disservice in so many ways to the issues of doctor-assisted suicide, because it was clear to me that he was making a name off it and grandstanding. But this is something you considered pretty strong. Do we have enough resources? Are we doing enough for people who, as you said, I don't want to suffer, okay? And if I decide to choose some route like that, whether it's hospice or DAS, do we have enough resources for individuals, good quality, high quality resources for people who contemplate that?
So it's different state by state. In California, you are allowed to do physician-assisted suicide. I don't remember the statistics. I think they're like 800 people a year or something like that who request it, and maybe only a third of them actually use it. So I think it's comforting to have it there on the shelf, that if I needed it and I said, okay, I can't take any more, I have some control over that. I don't have to suffer. I think about it, I think about, well, you go through this fantasy. I'm going to go to the pharmacist. They have to give it to you. They have to instruct it. They say, don't take it on the premises. It's like, are you going in for a beer? And so I have this fantasy to pick it up. Thank you very much. Sign on the dotted line. And then you go back home, and then what? Am I going to have family around? Am I going to have friends over? Are we going to have a little party? We're going to have a wake that I'm going to be at? It's a little ridiculous. But I find some sense that I'll be a little bit more in control. of my own death without having to suffer, without having to be intubated and, things that I don't want done to me.
I can tell you a funny story. But by the way, if some of you think about any questions you might have, and you're welcome to ask them. I can tell you a funny story about a physician-assisted suicide. A patient of mine, I became very close friends, some of my best friends are the kids. In 2003, he wanted DES for his restenosis, and we didn't have it here. It was unavailable. I offered him brachytherapy. He liked DES better. And I said, I got a friend in Milan I'll hook you up with, Antonio Colombo. And by the way, it was 25 grand. That's what Antonio's hospital charged. Pretty good, I thought. And they had their own jet. And I didn't know anything about aviation at then. I wasn't flying, but they said they went out. They went to Antonio, but they said, we're not going unless you come. So I went out. I think I was at that same restaurant with Antonio the night before. It was hysterical. We had a great time. We did this case together, and then we took the plane right back. And I was thinking about, well, this case better go well, or else this patient's going to be like in the cargo section. Like, well, this is going to be really, really awful. But it went great. And then 20 years later, he developed, he had heart failure, and he had orthopedic, a lot of problems. And he was at a retirement community, and he decided enough. And he was really struggling in and out of the hospital. And he was a very rational guy, very much like you, really thought through it and decided he was going to do it. And they had figured out just what you're talking about. The family was going to be just the kids and him. So they found a doctor who's going to do it. He's going to come and do it. I didn't hear the story about you have to take the pill yourself. At least in this, he was going to administer something, and right in this retirement community in their little house there, and the price was $8,000. That was what the fee was to do this, and you paid up front. But here's the interesting thing: the night before.
Otherwise, he would stiff him.
Literally.
But the funnier part was the night before, he dies. He is in VF arrest and dies. The family's there. And then the ultimate outcome is they got half their money back. That's your funny story. Physician-assisted suicide. Anybody else have any other comments, thoughts? All right.
Over to the left, Paul.
Oh, yes.
I can attest to his compassion and caring as a physician. He was my fellowship director, attending physician at UCI in 1984 to 1987. And every talk I've ever heard John give has been educational, but also entertaining and with overlying sense of humor and joy. And I just hope we see you back next year.
Thank you very much.
All right, if anybody else have anything to say?
John,
Yeah.
so I know one of the first things you said is you hoped you wouldn't embarrass yourself, and you didn't do that. You made us all look inward and
We'll make sure we get the honorarium check out to you as soon as possible.
Make it
and
fast.
I likewise am looking forward to next year's lecture. Wish
All
you
right.
the best.
Terrific. Well, we love you. Thank you for that. That took a risk. It was terrific, and I got a lot out of it. And I really got a lot out of it in terms of. I saw a brief of what you were going to speak about, and I was really touched by dying alone, the death by 1,000 cuts. I mean, and the idea that not suffering is really important, and that's something I can take to my practice. Just make sure your patients don't suffer. So, a really terrific lunch, and I'm just really grateful that you had the guts to do it, and you did it in your usual fashion with humor and grace and dignity and well-spoken. And thanks for all everything, including all those IBIS cases that you taught me about 30 years ago. So with that, I'm going to go back, tee up the next case. You guys, at 1:15, if it's in 10 minutes, if you could head back. We have a busy afternoon, and then I'm going to have a few martinis.